Welcome to the lecture on eating disorders. I'm going to start just by introducing the topic and explaining that although we see the physical ramifications related to eating disorders, we don't also see the emotional and psychological detrimental effects of this disorder in a lot of people from just observing them. So we're going to talk about this in detail and see the nurse's role in treating eating disorders. So the clinical picture, anorexia nervosa is the intense fear of gaining weight. It's not loss of appetite. A lot of people still have an appetite. They're just so afraid of gaining weight that they refuse to eat. When people hear the term anorexia, sometimes they think of a geriatric patient who has just not been eating because they don't have any appetite. That's not always the case here. So just remember, it's the fear of gaining weight. And there's two different types. There's restrictive type and binge purging type. In restricting, people severely limit their food intake, sometimes as low as 500 calories in a day, and they lose weight rapidly. The other type is the binge purging type. People will eat large amounts of food for even, 30 minutes up to 2 hours and then purge because they want to get rid of the food they took in, and one of the biggest ways to do this is to make yourself vomit, and that's what the binge purge type is. There's also bulimia, which we'll be talking about, and this is repeated binge eating, but instead of restricting, there is none of that, but they have this inappropriate compensatory behavior. So they may purge, yes, but they also abuse emetics. Emetics are the things that make you throw up that you can buy in the drugstore. For example, syrup of Epicat, if you've heard of that. Laxatives, they totally abuse that, like mag citrate or X-Lax or any of those stimulant type laxatives that make you go fast is what they use. They also use diuretics because anything that will give them some weight loss on the scale will benefit them emotionally. They use appetite suppressants as well to stop them from binging. Sometimes they will fast as well. They'll binge for 2 days straight and then fast for 24 hours sometimes, and they exercise excessively. So they can do maybe a binging, and then that night they'll go home and they will run for 2 hours on the treadmill. So excessive exercise, not regular healthy exercise. But I want you to keep in mind too, these inappropriate compensatory behaviors are also used by anorexics. Even though they haven't been doing the binge eating at all, they will also use this type of, besides purging, they will overexercise, they will fast, they will use all these drugs that people with bulimia have. Very common in both types. Then we have people with binge eating disorders, and they are the people that have binge eating for hours at a time or sometimes just one meal, but they don't have that compensatory behavior such as, making yourself vomit or exercising. So they gain weight, and they gain a lot of weight. So these are the people that you might see that are 300, 400, 500 pounds, extremely unhealthy people. The people that have bulimia, they usually have a normal to maybe slightly overweight and physique, and then people with anorexia are usually grossly underweight. So etiology, there are several biological factors. It has been shown that there's a possible 60% predisposition for people who have had anorexia in their family to also have it experience it themselves. And this can be a parent or a sibling or a grandparent, but a lot of people argue that is this really just something that's learned from watching a sibling with these behaviors. And then neurobiological. So it's known that they have altered serotonin levels, people who have eating disorders, and it contributes to this dysregulation of their appetite and their mood, depression, anxiety, especially because of serotonin, and impulse control disorders. So tryptophan, which is an essential amino acid, is necessary for serotonin synthesis, for your body to actually be able to use serotonin. That's available in food. You have to be at approximately 90% of your ideal body weight. Otherwise, if you're giving somebody serotonin in the form of an antidepressant and they're so severely underweight that their body cannot even utilize it because they don't have enough of the essential amino acids in their diet, it's not going to work at all. It's like giving them water. So, psychological factors. So there's a lot of theories about why people develop anorexia. Some people believe that it happens in teens because they're avoiding sexuality and they don't want to become grown up and they don't want to become a sexual being. They're feeling rebellion, or they might be having some feelings where that they want to feel power or control. And people say that this comes from having parents who might be overprotective. These adolescents sometimes fight for control over something, and one thing they can control is their food intake and their exercise and their how they look. But some people also believe it's a learned behavior, and that this is widely accepted because people receive positive reinforcement for weight loss. I'm sure that you may have experienced this yourself. For example, if somebody that you have gone to school with is out for a whole week of school because they've had an illness, severe illness, whether it's surgery or the flu or something, and they've come back and they've lost like 10 pounds, and they look to you better than they looked before, people might say to them, wow, you look great, you lost weight. And they think, wow, I need to lose more weight. I need to continue losing weight. If I've lost weight and people like it, I'll just continue to lose weight. So they learn to foster these behaviors to lose more weight. We also believe in environmental factors. Our culture's ideal of beauty is one thing that a lot of people say. If you look at the media and you see how thin the models are today, it's so different than it was 50 years ago with Marilyn Monroe, who was extremely curvy. And there's no research to confirm, though, that it's our media that says this is definitely an effect on people wanting to be skinny. But it's a commonly held belief. So there's also pure attitudes and behaviors that contributed to the body dissatisfaction that I've already touched on. So let's look at the nursing process in anorexia. Let's look and general assessment. There's subjective information and objective. So subjective is, what are they thinking about themselves? What are their perceptions about themselves? If you look at the picture on the slide, you can see that the person who is looking in the mirror sees herself as overweight, even though when you can see her back and see every single vertebrae and rib and scapula and her hip bones showing, and she's definitely extremely thin, that is not how they see themselves when they look in the mirror. Sometimes they'll say, I just have to maintain my weight. I don't want my thighs to touch. And they see anything touching, they get upset, and it makes them fast even more, try and lose more weight. So you also want to know, what have they been doing in the past? Have they had diet? Were they ever overweight? And what was their dieting history? What did they use? What methods did they use to diet? Did they use any of the things we talked about, like laxatives or purging or over-exercising or just restricting? What methods did they use? And were they successful? And are they continuing to use them now? So objective, what are the physical signs with anorexia they're looking at? They're looking at their weight being very low. You're looking at amenorrhea. They reach a certain weight loss and they stop having periods, females. And they may never start if they're early enough or young enough. They also have lanugo, which is that soft, fine, downy hair that babies are born with. They develop that as a protective mechanism. And they have like this yellow skin, very cold extremities. Sometimes they'll have swelling in their extremities as well. Constipation. Their body's GI system is impacted a great deal. And their heart, their blood pressure and pulse slow down because the heart is trying to conserve energy. And mental status and cognition have to be looked at. Are they having severe anxiety? How is their thought? How is their thinking? Is it rational at all? Sometimes when people lose a lot of weight or they're malnourished, they don't have the nutrients that they need for the brain to be healthy and to think properly and function properly. And what are their behaviors, their eating habits currently? How are their social behaviors as well? Usually people with anorexia have low self-esteem and they tend to isolate themselves. So the severity really depends on the level of care and the interventions. Also, as nurses, we need to look at ourselves, do a complete self-assessment. These are very challenging patients, and they a lot of times have a comorbid psychiatric illness, such as bipolar disorder, anxiety, depression, personality disorders, and oftentimes it's not a choice. Like a lot of nurses might say, they just need to eat. Just start eating. Why won't they just eat? Or the parents will say, I don't understand why they just don't eat, because it's not a choice. It's much harder for these patients. So in anorexia, there are several nursing diagnoses. The major one is imbalanced nutrition. The amount of food that's coming in is not enough to sustain them for their necessary body functions and physical activity. And sometimes it's so tipped because they are over-exercising at the same time, so it's really an imbalance. Because of this, they're not able to have a normal cardiac output. It's very decreased. When the body is burning all its fat and all its not getting enough carbs intake in the intake, they will burn their fats, but then when that's gone, they start using the protein that's in their body for nutrition. And one of the biggest sources of protein is muscle. Muscle, the heart is a muscle. And sometimes the heart is being attacked in this way, and so they have decreased cardiac output. The body is using the muscle of their own body to live off. They also have electrolyte imbalances, which predispose them for risk of injury. They become weak, they become lightheaded, they become dizzy. All these things will predispose them for risk of injury. Risk for imbalanced fluid volume as well. Dehydration. A lot of patients wind up in the emergency room because they've passed out from dehydration and they need IV fluids immediately. Outcomes identification. What's most important is going to be, of course, the weight gain, to maintain a sufficient amount of weight gain. For example, if somebody's going to be admitted to the hospital, they usually are going to be under, like a medical hospital, 75% of their ideal body weight. To be admitted to a psychiatric facility, it's usually related to the psychiatric illness, not so much. But what you want to see is when they leave the medical hospital or the psychiatric hospital, you like to see at least 75% of the ideal body weight regained. 90 is best. That is what they really look for. And then in planning that, what are the things that are going to be done? Well, they will plan for this ideal body weight. They will hospitalize them and keep them in the hospital if the weight loss has been over 30% of their body weight for the last 6 months, or they have a severe electrolyte imbalance, or they have acute psychiatric symptoms like they're feeling suicidal or they want to hurt themselves. The thing that is very important to watch for when somebody is hospitalized for anorexia is the refeeding syndrome. This is when people come in and they are so malnourished and dehydrated, they need to get them back to normal, but sometimes they try and give too much, too fast, and they wind up with severe metabolic changes. And you see them with severe edema. That's one of the first symptoms of refeeding syndrome, is seeing the edema. And they can wind up having some severe cardiac problems, and this can be fatal. Refeeding syndrome can be fatal if not caught in time. So some of the interventions that are necessary, first of all, safety in acute care, making sure if they're suicidal that they are in a safe place. Medical, if they're dehydrated, making sure that they're getting the IV fluids they need. As far as psychosocial interventions, the weight restoration program, and then that we just talked about, the goal is 90% of ideal body weight for a psychiatric facility, and then milieu participation. So what happens is when they're admitted to the hospital in the psychiatric unit, the inpatients eat in the day room of that unit, and they all eat together at the same time. And what this does is it provides the client with a kind of systematic desensitization to eating and feeling less and less anxiety with each meal. So they are sitting with other people. At home, they're maybe not eating at all, or they eat separately for their families because of the pressure they feel from their families. But this milieu, they have to eat. They choose their own food. They have to eat. And then they're all together. And then right immediately after they eat, in the milieu, they have a group. Lasts about 45 minutes. And they process this anxiety that they felt during the time that they were eating. It's a social time for eating, so they're encouraged to be social with other people as they're eating. But afterwards, they have the opportunity to talk about these feelings. And the hope is that after day of 3 meals a day in this situation, the anxiety lessens and lessens so that by the time they're discharged, they have so much less anxiety with each meal time. Also, there's drugs that are used for pharmacological interventions that treat the symptoms. If they're having anxiety, they treat the anxiety. If they're having depression, they can treat the depression with some medications. If they're having some impulses, like impulsive behavior, they have some drugs, medication for that. And they also incorporate some integrative medicine while they're there. They have yoga classes, some mild exercise classes. They use biofeedback. They have music therapy, art therapy, all those different things that are used. They have these groups throughout, and they talk about medications. Herbs are discussed, but only encouraged with the guidance of a physician or a nutritionist. They see a dietitian every single day they're there, and the dietitians are involved in the care, and they do the groups. They do a lot of the health teaching and health promotion about how to take care of yourself. They are encouraged how to cope with the feelings they have. They practice their social skills when they're in the hospital, and they practice decision-making skills in a safe place under the guidance of their therapist, who they do see while they're there on this unit. And they are provided with safety. Now, teamwork is essential. Again, as I said, it's a very structured setting and highly monitored. And the dietitian, the psychiatrist, the expressive therapist, the nurses, they're all involved in the care. Let's talk about bulimia nervosa in the nursing process. The assessment is the same, subjective and objective. The people with bulimia tend to have a history of impulsivity and compulsivity, and that's what causes the binge eating. They have subjective thoughts and behaviors that include similar to anorexia, but their behaviors include binging, purging, using diuretics, laxatives. They tend to get very depressed about this and feel anxious, and that causes them to have a very poor self-concept. Objective, their weight is, like I said, normal or close to normal, slightly over if not, but you can see signs. Sometimes I would take a patient into an exam room and I could tell right away just by observations that they had bulimia. And here's some of the things. If you look the slide to the left, you can see the redness and the calluses on the knuckles on that person's hand. This is called a Russell sign, and it is seen in people who stick their fingers down their throat to make them throw up. If you look at the slide in the middle with the teeth erosion, the enamel is eroded right off from all the vomiting that they do and the acid that's left in their mouth. A lot of times they do this in secret and they don't rinse their mouth out after they do it. And they develop this problem. And then on the far right, if you notice the person has this bulging parotid glands, swelling of the parotid glands, due to the over exertion of the salivary glands. When you're constantly throwing up, your salivary glands are overworking and they become inflamed and swollen. And so you might not see the inside swelling with the parotid on the salivary glands, but you will see it externally. You also notice that they'll have electrolyte abnormalities because of the prolonged vomiting that they'll do sometimes. Their glucose will drop, their thyroid stimulating hormone, because of what they do, will be altered, their CBCs, their EKGs because of cardiac output. All these things are objective findings that you would see for bulimia. So some of the diagnoses and the outcomes are similar again to anorexia. Decreased cardiac output, disturbed body image, ineffective coping. They feel powerlessness, chronic low self-esteem that leads to the depression and social isolation. Now, outcomes, you want to see their electrolytes become imbalanced. You want to make sure their cardiac output stays adequate. You want to encourage a satisfactory body image. You want to help with effective coping and help them become confident in making their own choices and decisions. And they also need to know, and this is important, when they're healing, and you can tell when someone's healing from an eating disorder because they have a willingness to ask others for help. They know that, okay, I'm getting in a situation here where I feel like I'm a little out of control. I'm not sure I can make a good decision here. I'm going to ask for help. That shows they're improving. That shows one of the positive outcomes that you want to see. And you want them, instead to feel isolated, you want them to feel a sense of belonging. So some of the interventions you're going to do, sometimes it'll be in a hospital for bulimia. Not as much as, anorexia, because it's usually not as severe. And sometimes the eating disorder unit will have patients with bulimia because of the severe thoughts of self-harm. Again, need to have the teamwork and the same structured milieu that you would have. This can be done not only, though, as an inpatient, but as an outpatient as well. So what you'll do, when I say structured milieu, this can be a very different team, not just the inpatient team, but an outpatient team. A lot of people come into the hospital, will be admitted, they'll stay a week to 10 days sometimes, and they'll be what they called discharged to a lower level of care. They'll go to outpatient anorexia program in the hospital. That's 9 to 3. So they'll eat breakfast and lunch in the hospital, but go home for dinner. And if they're successful, then they can continue that for a month until they're just going to therapy or periodic groups. If they're unsuccessful, they are stepped back up into inpatient to see if they can try again. Now, some people go from the inpatient hospitalization to a residential facility. So if they're doing well with the hospital programs and they go to residential because they're not ready to go home yet, that is a long-term care with a large team and, again, a structured milieu as well, but not as structured as a hospital. So medications that are used are the similar antidepressants if needed, and Prozac is one that has seemed to help, as well as tricyclics that have been helped with prolapse. So SSRIs and tricyclics are used to treat the symptoms. Counseling is very necessary for these patients, and health teaching and health promotion that focuses on the diet, healthy exercise, healthy coping, and cognitive distortions. Look at their irrational thoughts and help them turn them around to become rational. Binge eating has rarely caused someone to be hospitalized unless they have severe thoughts of harming themselves. So binge eating, you're still going to do a general assessment. You're going to look at their eating, the timing of their eating, the type and amounts of foods that they eat. Some people will go to fast food several times a day to Taco Bell, McDonald's, Steak and Shake, all those. And it won't just be once a day. It'll be on their way to work, go out at lunch from work or school, on their way home from work, before they're eating dinner at home. They'll go out at night and stop on the way home and have another meal. 3 or 4 times a day, they're going to fast food restaurants. It can be extremely, extremely expensive and causes problems with a lot of relationships and marriages because of this. But they also have triggers for binging. So it's good to know not only what they're eating, how they're eating, their types of food, but what their triggers are for stopping, say, and binge eating. Are they having GI complaints? Because that's one of the major things that happens. And are they eating in an isolated area, in their car alone, or at home alone, in their office? What kind of lifestyle do they have? And see if they've had a loss of control with their eating. Objectively, they are usually morbidly obese, and they have a lot of medical issues related to morbidly being obese, such as high blood pressure, high cholesterol, elevated sugar, diabetes. That can be something that's undiagnosed with these people that tend to binge eat. And then self-assessment, try and be aware of negative reactions that you might have to patients. It's really hard not to stare for some people at patients that are 300, 400, 500 pounds. On the eating disorder unit, we have had patients up to 500 pounds that are in special chairs and wheelchairs because they're so obese they can't walk far. And then you have the people in the wheelchairs on the same unit that are restricted in exercise. They're not allowed to walk because it burns too many calories. So you have them on the same unit. They look at each other with a negative reaction, and it's just for yourself to be able to model being non-judgmental for other staff and patients. So nursing diagnoses are going to be related to things like altered nutrition, more than body requirements, and the psychosocial that are very similar with anorexia and bulimia, low self-esteem, ineffective coping, and things of that nature. So we've gone through some of those, but outcomes identification is they really need to focus on losing weight in a healthy manner through diet, through medical regime, and exercise, again medical, if they are severely obese. But these patients have such a difficult time with weight loss that a lot of them have gastric bypass surgeries, and they have really had a terrible problem with their stomach, with their esophagus. They may have tears, they may have herniations, hiatal herniations near the diaphragm from overeating. They have really problems with constipation and diarrhea, all sorts of things. This is really a medical necessity to have somebody follow them. So the interventions we talked about, they are usually not inpatient unless it's a GI thing, medical GI, or they want to hurt themselves. So they use cognitive behavioral therapy and dialectical behavioral therapy, talk therapy, and they do use with the medical, we talked about, diet pills, especially if somebody has a BMI greater than 30, or if it's 27 and they have a medical issue. Hypertension, high cholesterol, or something like that. And the bariatric surgery right now is controversial for somebody who is extremely overweight. It seems to be less effective due to the history of the binge eating. And then diet, exercise, and coping need to be addressed as well. So you're going to be asked to do this activity at home. You will have received a worksheet for Shannon, who has anorexia. And I expect that you will answer the questions at the end of the worksheet, write them out by hand, and bring them to class on the following week after you watch this lecture. If you have any questions, of course, feel free to contact me, but this is the end of this lecture.